Good afternoon, everybody. So we're gonna start a wrap-up interview for the first hour session, New Frontiers in Cardiology. First of all, thank you for joining us, and so really happy and honored to have very distinguished speakers in our session. Dr. Muse and Dr. Loh from United States, Dr. Bax actually is from Netherlands, Dr. Miura from Japan. Really, thank you for joining us, right? So, in this session, we'd like to briefly, summary of your talk and the really, future perspective what it is. And so, you want to start with Dr. Muse.
Sure, thank you, Dr. Park. This morning, I had the privilege of starting out by kind of taking a future view in digital medicine and how, these changes in technologies are going to be able to benefit our patients and us in the clinic very soon. There's been a rapid growth of our computing power and interconnectivity, and now we have sensors spanning head to toe. But the questions are still out there as to, which apps, which sensors, and which kind of analytics are going to drive really improvements in our care for our patients in the future. I think that one of the big issues that we're facing now is empowering our patients, right, and engaging our patients. It's not just taking one of these apps or devices, throwing out a problem and expecting, the solution to just come out of the blue. I think that we're going to have to develop better environments. Think outside of the traditional box of just the electronic health records and et cetera, and really bring in consumer genomics, wearables, and analytics to provide insight to our patient. We always talk about how to engage our patients to take their medications or to exercise more in preventing heart disease. We haven't done so well at that in the past. I think that now's our opportunity to learn from the folks in behavioral economics, to change up our message, to really communicate with our patients and bring them into be co-producers of their medical outcomes. I think that the future of digital medicine is really strong. We've learned a lot through our failures over the past several years, but it's institutes like our own in San Diego and certainly others that are working to try to figure out, where the power of digital medicine in the future.
Dr. Miura, I have my personal concern in digital medicine is that everything has both sides, and the desired aspect of the digital medicine, like big data, helping us in the diagnosis or risk stratification. But on the other side, an undesirable aspect of the wearing devices, helping doing more for the hypochondriacs than for the sick. So I'm really concerned that if we left it alone, I'm wondering whether the direction is skewed to the undesirable aspect. So is there any way we can direct the direction to the desirable aspect, or at least the balanced progression?
That's a great question. A lot of people have voiced concern about what we call mobile health-induced cyberchondria, right? Finding, when the AliveCore came out, cardiologists feared that, all of their patients would send them single-lead electrocardiograms saying, what is this? And it's just normal sinus rhythm. I think the onus is kind of threefold. Number one, it's on device manufacturers to come up with integrated solutions to inform their patients about what kind of signal they're getting from these sensors. Number two, on us as the physicians, we have to be clear in communicating what the goals and expectations are of using particular sensors. Make sure that we are empowering our patients, the appropriate patients, to match them with a given device, not just give everyone with AFib the same device. We have to recognize that there is the potential to cause great health anxiety in this space, and as well integrating our medical system to make sure that we can have better ways to communicate with them instantaneously or through the health record, so we don't lead to ER visits at home created by anxiety. I did have a patient that had two different trackers, one on each arm. It drove a little bit of anxiety for him. But I think that what we've learned is we can develop educational modules within these applications, et cetera, to get beyond that.
Dr. Mills, we need digital medicine or precision medicine approach, not only for the treatment, but also for prevention of cardiovascular disease. Can you talk a little more about the digital medicine or precision medicine in the field of primary prevention of cardiovascular disease?
Right. I think that it's going to go back to some of the things that Dr. Bax talked about earlier on in terms of imaging, right? We've got new imaging modalities that can provide us with potentially new levels of risk assessment, even in the primary prevention. It goes back to being able to incorporate genomics into the derivation of one's clinical risk. One of the things I got to talk about this morning are polygenic risk scores and how using digital apps and smartphone-enabled tools to be able to deliver that sort of data, not only on coronary artery disease, to help you decide potentially when to start a statin or how much exercise, weight loss, et cetera, that you need, but also in the realm of atrial fibrillation, right? We have the ability to risk stratify individuals for atrial fibrillation based on their genetics, and we know that there are a lot of lifestyle issues that could potentially prevent the development of permanent AF and the need for antiarrhythmic therapy in the future. So I think some of these components of both imaging and genomics coming through will really empower us to get better analytics for primary prevention.
Thank you. Thank you for the summary. As a next Dr. Bax, you want a future, perspective on microimaging. So would you like to some summary for that?
Thank you. It's a real pleasure to be here. I spoke in my part in this session about non-invasive imaging, and we see also a lot of advances in invasive imaging, which we did not even speak about. I think we have certain holy grails that we're looking for, predicting who gets an event, predicting whose outcome is better with whatever therapy. As I tried to lay out in my talk is that we have 4 major modalities, which is echocardiography, which I think is for the general cardiologist the tool that we use the most. It also comes without radiation. It's very easy to use. We did not even speak about handheld echocardiography, which I think is a challenge along the lines that you discussed, because we can now take a quick picture with almost a stethoscope it is of a patient, but we have no idea how to store that, how to report that systematically. So if the next day you come back or the next week you come back and something has changed, and then that picture isn't there, so how do we deal with that? We spoke about echocardiography. I think also that the field of echocardiography is changing. The echocardiographer used to be somebody sitting there in his room outside of the department, basically. And now he's fully in the department because he or she plays a very strong role in the cath lab, coaching and guiding the procedures, mitral clips, transcatheter aortic valves. Soon there will be more in the tricuspid space, LAA closure, PFO closure, ASD closure. So there's a lot coming. Echo, we see also that it's moving from 2-dimensional to 3-dimensional, and soon it will be 4-dimensional. I think that is important. There's a lot of technology developments also in the field of echocardiography. So that's about echo. I think MRI is a technology, in my opinion, that can do everything, but the access is limited for the simple cardiologist. We can certainly not do, as we do maybe 150 echoes in a day, we can certainly not do 150 MRIs in a day. So we have to ask ourselves, which patient goes to what modality, and certainly not put every patient in every modality. That's important. MRI, therefore, I think, although it can assess everything, the strength is to assess the muscle, looking for scar tissue, and looking for inflammation, and looking for fibrosis. And specifically fibrosis, we did not spend much time, but fibrosis is probably the way of early detection that something is going wrong in this ventricle. Let's take a severe aortic stenosis. constant pressure overload, you get hypertrophy, but still everything looks okay. Then you take out the valve, and later on the patient develops heart failure. Why? Because there was already fibrosis formation as a reaction to this constant hypertrophy formation. So I think MRI is going to go in the direction of function and muscle imaging. Then the third player that we discussed about is CT, and the big business at the moment is happening in the CT because it's very quick, very fast, can assess also a lot. It started with CT anatomy. Is there a stenosis or no stenosis? Now we can non-invasively do the FFR on that stenosis. Soon we will get more information about plaque vulnerability. That's coming. We start to realize that certain plaques, specifically non-calcified ones, are more vulnerable than others. The challenge here is when to use this CT, in who and when and what. And so you spoke about the early detection, the primary prevention, that you can potentially address with CT angiography. The question is, do you want to do that in everybody? And is everybody where we see things getting an event? And those links we absolutely don't have. So I think CT is a wonderful technology that gives a lot of possibilities. But what I often say is that our technological advances at the moment are a little bit outpacing our clinical understanding. And that's also what we see in your business, that a lot of things we can do, but we don't know the consequences or the interpretation of it. And that can result in overdiagnosis, overtreatment, anxiety with patients. We see that not in the Netherlands, but in Germany, you can get a CT scan not in a heart center, but outside. In the US, that's also possible to some extent, I think. And that creates a lot of anxiety with patients. They get a scan done and they don't know what to do. And often we also don't know what to do. So you give medical therapy, but we don't know when to revascularize, yes or no. And so I think, yes, the technology is going very fast. And a lot of things are being possible. But we need as physicians to always maintain that contact with the patient and to keep on constantly asking ourselves, what sort of information do I need to treat that sort of patient? And then the last technology we did not speak about is nuclear medicine, which is also developing very fast and gives us a lot of potential information about inflammation of the muscle and inflammation of the coronary arteries. And specifically, if you fuse the CT with the nuclear cardiology techniques, that would bring us even more information. So a lot comparable to what was said, big data, large information, be careful with the interpretation, and always think about the patient that's sitting there opposite of you to ask you questions what to do.
If get together with digital medicine with CT imaging is really
Something amazing, man.
right, amazing. So, Dr. Song, would you?
From your talk, we can have the insight that nowadays we can get the histologic information as well as morphology information from the cardiovascular imaging as scar or fibrosis. Once there is a promising perspective that we can get the molecular information in nuclear medicine or cardiac MR spectroscopy. But nowadays, the topics are questioned. So, is that not promising anymore, or?
Well, I think the MR spectroscopy is very important, and it brings us a lot of, let's say, biological information. But the issue is that it's technologically demanding. It's not easy to do. A lot of artifacts. And that then limits the use in the daily clinics. Also, if we see certain informations, we don't know yet what to do with it. So I think this is in the time where it is under development, and it needs to still show where we're going to implement that in a clinical setting. And it also needs some technological improvements to make it readily available. But the most important question for me is really, where do I implement this information in my clinical daily management? You spoke about molecular imaging at the level with nuclear. Now that is very promising, I think. If I would put my money on something for the future, it's probably the combination of that with CT. Because look at the work from Newby and Dweck in the UK. They show these coronary arteries, they do a CT scan, then they do the PET with it, and they show with the sodium fluoride that they can pick up the potential vulnerable lesions. So I think that's very, very important. If we can better identify at an early stage who has a vulnerable lesion, and we have a good treatment, then we make big steps forward.
Thank you, Dr. Max. And so we're gonna move future of cardiac epidemiology. So Dr. Miura, would you summarize that one?
So, because my major is cardiovascular epidemiology, today I talked about the history of the cardiovascular epidemiology, and also I talked about some of my thoughts about the future of the cardiovascular epidemiology. So, in the past 100 years, so cardiovascular diseases are epidemic in the world. So many studies are done, and we found many factors that of the cardiovascular diseases, and many of them are nutritional factors, which is close to the cause of the disease, and also many factors are risk markers of the organ damage of the cardiovascular diseases. So, and the problem is that how we can use these factors to prevent the cardiovascular disease. So, I talked about the future of the preventive medicine. For example, risk stratification of the people, and how we can prevent, and also how we can treat by medicine to prevent the cardiovascular diseases. And then another point is that in Asian countries, East Asian countries, the stroke is dominant, but the coronary heart disease is less popular, but it is increasing. But so we have to think about this kind of type of the cardiovascular diseases for the prevention.
All right.
Dr. Miura, you have been involved in many international collaboration study with European or American countries. Do you think we need a different epidemiological approach in the East Asian country?
So I think that the big difference in the type of cardiovascular disease is between Western countries and Eastern countries or Asian countries is mainly related to the different lifestyle and the dietary habits or other factors like smoking or alcohol drinking or so. So I think that this kind of lifestyle factor is very important, and the prevention strategy has to be thought in each country, looking at the epidemiological findings of in each country. So but they also common lifestyles also exist in the modern world. So we have to care about such kind of lifestyle.
Okay. All right. Thank you, Dr. Miura. So we want to move to the last talk, Dr. Loh. So summary of the future anti-thrombotic therapy.
Well, as I've described, we've had 3 decades of experience now in developing antithrombotic therapy, starting with aspirin. And multiple different therapies have been developed, tested, and now are used in practice. But what's most important is that even those therapies, once they're approved in practice, we continue to study them, and we continue to develop evidence about the best use of these therapies. So take, for example, glycoprotein 2B3 inhibitors. Initially thought to be very promising, were widely used, and then subsequent trials were done to show that the benefits of those therapies were not as great as what were originally shown, especially in contemporary practice, and the risk of bleeding was higher. So we've seen declining use and changes in guideline recommendations. Concurrently, also, we've seen that different combinations of therapies are probably what is most important, and finding the right combination for the right patient in the right situation is critical. And I think all of the presentations have all had some aspect of that focus, and that is, what is the right digital health strategy or device for a patient? What is the right cardiovascular imaging approach for the patient? And then the intersection of the patient and the provider to make a decision based upon that. And then what are the epidemiological factors that are involved on the patient level, maybe on the country or regional level. I think the same can be said for antithrombotic therapies, and that is, one dose doesn't fit all types of patients. I think you've learned that very well in Korea and other countries in the Asian region. I think one therapy doesn't fit all patients, and there are multiple different options to use and customize. But then I think, as Dr. Bax and I had a nice discussion about, our guidelines need to be updated more quickly and more regularly as new studies come out. And I'll speak about other studies this afternoon with the novel oral anticoagulants and how they can be used in the treatment of patients with coronary artery disease. So I think it's a time right now where evidence is being developed regularly. We need to be responding to that quickly, and we need to be giving guidance to our providers, but also to our patients. And so good decisions can be made, shared decisions between the providers and the patients about what drugs, what dose, what combination, and for what duration. So it was really a pleasure to put the talk together and present it to kind of synthesize thoughts, but we still have a lot of work to do, and I look forward to working with you and your colleagues in Korea and other countries as we seek to develop new agents and better use the ones that we have.
Really, you just mentioned about some Asian peoples and Caucasian peoples. Many studies, many participate in the Caucasian, something like that. And so, even in the aspirin Plavix dual, combinations, we don't have any systematic literature review concerns. However, we have quite enough, ethics concerns, safety concerns, and not too much, stent thrombosis or something like that. And so, however, the Prato study moved to the, ticagrelor, the aspirin ticagrelor, and then we really are concerned about the breathing, Prousgrel, ticagrelor. After that, you may know that 60 milligram of ticagrelor is available in our Asian Pacific Society. And so, really, what do you think is in terms of any really determining, racial difference in terms of
I mean, in certain drugs like clopidogrel, we know that the genetic polymorphisms differ in their prevalence in the Asian populations compared to those in Western countries. So there's a clear example that we didn't know early on, and we only learned that after the drug was on the market. We also know that other drugs, we probably don't get the right dose, and there probably should be a range of doses that we use. In earlier phase studies, we should explore that, and we should involve more patients from countries like Korea, Japan, and others in this area. And I know you have great capabilities in Korea to do clinical trials. And so as I talk tomorrow about pragmatic clinical trials, I think we will all have opportunities to work together in different ways in early and late phase trials in the future, specifically with antithrombotic therapies, to do a better job of determining the right dose, again, for the right patient, the right situation, and then in bigger studies, test multiple doses, not one dose for every patient around the world. That just doesn't make sense. And so I think we're starting to learn that, and I think we have great opportunities to collaborate on that in the future together.
Okay. Dr. Song? No? All right. Any others, comment on discussion points from the AG speakers?
I think that what we see is that we live in very exciting times. And Rob Califf came to ESC, and we were in the same session, and he spoke about the fourth revolution in developments. And the developments cascade so fast at this moment that it's hard for a physician and a patient and any individual to keep track of all these things and to position it. And I think what we witness, for example, in the younger generation, that there is a lot of overload coming to, let's say, the young medical students in all the possibilities. So with all the opportunities come also big challenges, and in my opinion comes big responsibilities, that we as people who are working with these things and developing these things, that we lead it in the right direction to make sure that everybody benefits from it, and that we do not add to a lot of confusion, what can also happen easily.
I would add that what you're describing is adaptive but strong leadership. And that's what's needed as we train the next generation of providers, but also the next generation of patients, right? So that we can work better with them. So, so I really like your thoughts, Jeroen, and I second those. And I think we all need to take on that mantle of leadership and help sort through the confusion and provide some clarity, but also learn how we can take much more information than we previously have ever had available and use it for purpose.
Yep.
Okay, it's really thank you again for joining us. It's really honored to have you all for this wrap-up interview session. So personally, I was very impressed, and I really have a brilliant future of intervention. I don't know, not even the intervention cardiology field, and even the longer life and good quality of life, and right. Really, happy to have you all. Right. Thank you very much.